Hello, you're listening to the latest season of the COVID Inquiry podcast. This week, Nicola is joined by Lorelei King, actor, screenwriter, narrator, and most pertinently, a member of the COVID-19 Bereaved Families for Justice group. Together, they're going to reflect on how the recent hearings went and look forward to the next few days of evidence. Please note, some listeners may find the contents of this podcast distressing.
Hello everyone, I am Nicola Brook. For those listening for the first time today, I'm a solicitor at Broudie, Jackson, Canter, and I act on behalf of Bereaved Families for Justice UK in the COVID inquiry, which is the inquiry the families campaigned for. As usual, I'm here with my co-host Lorelei King, who is a member of the group, having very sadly lost her husband to COVID. Today, we are joined by two guests who gave evidence this week. First is Julia Jones, who is the co-founder of John's Campaign. So where someone is being accommodated in any of the institutions of UK health and social care system and is in need of additional support, John's Campaign campaigns for that extra support to be provided. Our second guest is Nicola Ritchie. Nicola is a physiotherapist in NHS Scotland, but after suffering from long COVID, she is also now a member of Long Covid Physio. Welcome both.
I'm so grateful to both of you for coming. I'll probably say Nicola R and Nicola V to avoid confusion. This week was very interesting for me with the themes, but I would like to start by talking a little bit about the impact video, which they've split the impact videos into two for this module, and we heard the second one. For me, my husband died in care. He had young onset dementia, and I found it particularly heartbreaking, the testimony of a woman whose husband had dementia. And because she couldn't visit, he thought he'd done something wrong. And for me, I feel like whatever we do in the future as regards a pandemic or anything has to ensure that this cruelty doesn't happen again. And I'm so pleased to see that you're both here to talk about it. Julie, I know you'll have things to say about this. And to me, the theme of this week was the lack of care for those with special needs, a lack of understanding and accommodation. And this went from quite specific needs, like Dr. Sarah Powell, who is deaf and couldn't get interpreters, sign language interpreters, to something that affects many more people and is perhaps generational, like Caroline Abrams talked about the digital competence of older people. But Julie, I wonder if we could talk about your evidence first and about the work that your group does. You said, I know you were concerned that the infection prevention and control needed to be a lot more nuanced for people with their individual needs, and that there should have been more consultation. I just wonder if you could tell us a little bit about that.
Lorelei, I think you're the person who has the best, most direct and most painful understanding of this. Yes, John's campaign started life as a dementia campaign. We both, my co-founder Nikki and I, had parents living with dementia. Nikki had the experience of seeing her father, well pre-pandemic, go into hospital, fit, well, mobile, for a procedure. But then because of inflexible infection control, because there was a norovirus outbreak, the family were banned from visiting him, caring for him. And his decline was total and catastrophic and irreparable. And Lorelei, my dear, I fear you might know this better than anybody, that there are, I think, is it nearly 1 million people across our countries living with dementia, and it's incurable. And all you can do is either do your best to keep it steady, and the only way to do that is person-centered care, or you can make it worse. And everything that was inflicted on people with dementia during the pandemic made it worse. I nearly feel so passionate. I nearly feel that the physicians do no harm oath was seriously damaged. I almost feel that Article 2 of the Human Rights Act, the right to life, was infringed because these were known risks. My co-founder, Nikki Gerard, went on TV on March the 13th, 2020, and she said from her own painful knowledge that for people with dementia, there were worse things than COVID-19, and separation and isolation are those worst things, and they are killers, people with dementia.
You're right. Actually, I'm getting a bit emotional here because, I can never be glad about my husband's death. If I'm grateful for anything, it is that he died on March 31st, 2020, at the beginning, that we were only separated for a week. I cannot imagine the pain of families who had their loved ones that they couldn't see for a year or more. I can't imagine. And I can't believe I'm this emotional. I won't apologize for it because this is reality. Um, and I'm very grateful for a campaign like yours. But I think this has to be a, really important part of the platform moving ahead. If we talk about lessons learned, I think it has to be a really important part of it. I know there are no easy answers, but we cannot torture people in this way. It is cruel and inhuman.
It is absolutely cruel and inhuman, and it is straightforwardly wrong. And in fact, Lorelei, the laws like the Equality Act, I know Nicola wants to talk about people with particular needs, and clearly dementia is a disability, as other things are disabilities. Mental health is a disability. Age, many things. About a quarter of our population could be covered under the Equality Act. And we need to be in a situation where we remember that we made good laws like that, which say that people with these particular needs are legally entitled to reasonable adjustments. It's not somebody just being nice, it's a reasonable adjustment. And I cannot understand how the infection prevention and control people sat there drawing up their blanket guidelines with absolutely no thought for the people who are going to be terribly, irreparably impacted by them. How could they have been so ignorant? And how could nobody have said what you're doing is unlawful? In fact, in the care home situation, we in the end took the government to judicial review because we said what you are doing is unlawful. But by that time, we were 6 months into the pandemic, and I understand what you say. My mother-in-law died just before the pandemic, and my mother died the year before, and I am so grateful because my mother could not have understood why I wasn't coming to her. I went to her twice a day, every day. She would just have thought I didn't love her anymore. People with dementia feel so strongly, and they can't express it, and it's simply horrible.
It was. I'd like to, in a minute, I want to come to Nicola B and ask her thoughts about your testimony, but I just wonder if I could ask you, Julia, what you think could be done in future to help the situation, to mitigate some of the horror. What can people do? What could the government do now, or organizations do now?
Well, one of the things that we've recommended, which I hope other groups will pick up, is that the good laws that we have, such as the Equality Act or the Mental Capacity Act or the human rights legislation, should be remembered, should be preeminent, and that actually people working in health and social care, as part of their training, should be aware of those laws, and that they, working a public institution, have a responsibility to be aware of those laws. But actually, we go further than that now, because I said in my evidence, Nikki and I used to believe that good things would happen because good people would champion them. And until the pandemic, we thought that was true. Many trusts had pledged to welcome carers of people with dementia. It was looking positive, but it wasn't deeply rooted in the culture. it didn't really work with the psychology of frightened people whose instinct was to slam their doors and say no and treat family care as if they were just sort of walking infection bombs, which was so insulting, because the people who care most about not infecting the people they love are the people who love them and had probably been shielding to keep them safe. It was completely wrong-headed. But anyway, we now have a very definite goal in mind, which is to get a parliamentary act. It would be an amendment to the 2006 NHS Act, which says that people living in or being treated in any health or care setting have a right to a person who is special to them if they want it. And that just needs to be a legal right that everybody knows they've got it, that families know they've got it, the social care and hospital settings know that this exists. Therefore, they have to plan accordingly. They can't just say, oh, well, it was too difficult because, or, well, we would have loved to, but we just couldn't. Because if it's a legal right, they just have to. And they have to safely. And nobody's forcing anybody to go in who doesn't want to. And nobody's forcing anybody to have anybody if they don't want to have anybody. But there should be that fundamental right for every citizen. We can only manage it in England to start with, but I would like to think if we manage it in England, that the other countries would soon follow.
You said something that really struck me in your testimony, and I hadn't really thought of this before, because you were talking about the NHS, and you said the whole purpose of the NHS, of this institution, is the patient,
Yes.
and that we weren't there to protect the NHS, we were there to save individual lives, to protect
Yes.
individual people. That really struck me. And I thank you for saying that, because I think it's easy to forget, particularly with the messaging we got about saving the NHS. Nicola B, what did you make of Julia's testimony when you heard it?
Incredibly powerful, Lorelei. I think it's very easy for people who don't have loved ones in any kind of care setting, or indeed going into hospital during the pandemic, to not really understand what it's like to be separated. It really came across loud and clear that the people who were making decisions were so scared of COVID, and they were right to be scared, but they lost the idea that actually for some people there was something worse than COVID. And for people with dementia, that separation causes such a deterioration in their physical health, not just their mental health, but their physical health. And that was something that I certainly didn't have an appreciation for. And that's why evidence from people like Julia is so important. But also for people like our own client, John, who lost his daughter, Susie, because she had Down syndrome, she wasn't able to understand the importance of wearing a mask in hospital. And there was no one there to be able to explain it to her in a way she understood. And therefore, because of her learning disability, she suffered a physical deterioration. And for Nicola Ritchie, who's joining us today, whilst COVID may not have been that bad, the long COVID has been absolutely devastating. And I get very frustrated when the message is the best way of guarding against long COVID is to not get COVID. So many people my age and younger were like, well, it won't be that big a deal for me. I've got 3 teens. They weren't scared of it at all because the message was it won't have an impact on you. They were all sensible and took the precautions because they knew they had elderly relatives. But for their own sake, they weren't scared. And actually, long COVID could have been so much worse for them. And that message was never conveyed.
Yes, we've talked about people being let down in the past. We just talked with Juliana, but for Nicola R as well. People are still being let down. And your lived experience testimony, the impact testimony you gave was very powerful. And having listened to all the testimony over these modules, I'm so sorry for how you were let down as a health worker, being fit for a proper mask and then not being supplied a proper mask. I'm so sorry for that. I wonder if you could tell us a little bit about your testimony for those who may not have been able to hear it.
Yeah, of course. Well, I am a physio. I work within mental health setting. And going on what Julia was saying there, I saw firsthand the impact that it had on so many patients. I saw the fact they weren't able to get visitors coming in. We had patients that were long-term patients. We had dementia patients. We had so many patients. And the fact that they weren't able to see anyone, any loved ones, any carers, anything like that, coming in to see them on a regular basis. An iPad was the best we could do, or a phone call. And so many people find that so confusing. They just couldn't handle it. And I did find it incredibly sad to see. It was terrifying from a staff perspective. When we did open back up and all the visitors were allowed back in, we were all worried about that, but we knew that it had to happen for the patients and their well-being. It was so important for them. It really was. In terms of myself, I caught COVID at the very beginning of the pandemic and have never really recovered. I was face fitted for an appropriate mask, but I was never allowed to wear it because I officially wasn't carrying out an aerosol generated procedure, even though I was going in rooms with coughing patients and we were doing quite close contact work with them. That wasn't classed as an aerosol generated procedure, which I thought was absolutely ridiculous. The PPE that we were provided with was substandard. It wasn't fit for purpose. And as a result, I caught COVID in the workplace. Subsequently, going on to contract long COVID, which has absolutely devastated my life. I am now classed as disabled. I have to use a mobility scooter to get around. I have a blue badge. I used to assess people for blue badges. Now I have one myself. It's quite challenging. It's quite a difficult position to be in. I'm still in work at the moment, but I really don't know how much longer I will be able to stay in work for because of the disability that I have. I'm very restricted in my day-to-day life with what I can do. It's everything is paced. I have to make sure that I don't overdo things every day. So if I have an appointment, I've got a doctor's appointment, even if it's a phone call appointment, that's my one thing I can do in a day because that cognitively exhausts me. And cognitive challenges are just as difficult as any physical challenge to me. So it's so frustrating when all I want to do is go out and do things and be spontaneous and be my normal self, but that's no longer my situation. So I have to live with that and I have to get used to that, really. It's taken quite a while.
I've learned by attending the inquiry, I have to say I was pretty ignorant about long COVID, and I am shocked how disabling the disease is from the people who bravely, with long COVID, who bravely fight to come to the inquiry. Professor Rachel Evans, who gave testimony this week, she said that anyone is at risk of getting long COVID. And I've been thinking about this as this is where we seem to be now as a culture, that people seem content to get the disease over and over again. And that's kind of a Russian roulette, isn't it?
It really is. The more infections there are, the more the chance of the person developing long COVID. I find the fact that the world seems to think that COVID is over is shocking. Why does everyone seem to think that COVID no longer exists? 2 weeks ago, when I was walking down the corridor, well, not walking, I was using my mobility scooter in the corridor at work. I had someone turn around to me and say, "What are you wearing that mask for? COVID's over, didn't you know that?" I had no words to say, but that's the sort of thing that I have regularly. When I go out wearing masks, I get so many strange looks. it isn't over. It's still very much apparent, and the more people get COVID, the more they are likely to catch long COVID. And it isn't just a mild flu-like illness. It can be devastating.
I know it isn't over. I'm a volunteer at the UK National COVID Memorial Wall, and every week over 200 people are dying every week from COVID now, and we add to the number on our banner of COVID dead. It is not over, so I'm not surprised. Nicola B, can I bring you in on this?
I think one of the aims of the inquiry has obviously been to learn lessons. The other is to make recommendations that will save lives in the future. I really hope that it does a little more than that, and it actually leads to whole-scale recognition of long COVID, because we've heard time and again of the difficulties people have had in getting recognition of the condition. And most alarmingly, amongst the healthcare workers, who have been incredibly dismissive of it in some instances. We've heard about the closure of long COVID clinics, and yet the instances of long COVID is going up, not down. Some people are making recoveries, but it seems like the vast majority aren't, and that there are new cases of long COVID every day. So that need for the clinics isn't diminishing. So I really hope that the inquiry gets the message out there that long COVID is indeed an actual condition. I know some people have been told it's all in their head. I hope there's more recognition of the fact that whilst for some people exercise is the right thing, but for long COVID, it really exacerbates their conditions. And Nicola, I'm so sorry if even just attending on this podcast is the one thing that you get to do today. But I do hope that by sharing your story, it provides an education to the people who need to know more about it.
One thing that struck me in your
Absolutely.
testimony, Nicola R, was just how you were left to your own devices to find solutions online, but your own GP told you that. Julia, can I ask you to come in on this?
Oh, thank you. Just one of the things that has surprised me, and reading Nicola's testimony again, it amazed me again, is post-viral syndrome was already a known thing. One of my children, who was 14 at the time, caught swine flu, and this is why I was thinking also about your teenagers, and yeah, he was 14 and he caught swine flu, and his temperature rocketed up, and then it rocketed down, and then it rocketed up again, and I just did the normal things that mothers do, as fluids and paracetamol and all that. Didn't think anything more about it, and he wanted to carry on with his normal life. But it very soon became apparent that he couldn't carry on with his normal life. And it was then said, oh, you've got chronic fatigue syndrome. Now, chronic fatigue syndrome is another one of those ones where people say, oh, he just didn't want to go to school, or he's a shirker, or whatever. And as a parent, it was ghastly, because in the end, he was referred to Great Ormond Street Hospital. And they started doing sort of, psychological tests. Were his parents being unkind to him, or was he asked if he was suicidal? He wasn't. He was ill. He had post-viral syndrome, but it literally took some years before he was able to realize that this was what it was, not something in his head, and he wasn't sort of weird or faking or whatever. And he was put on then a very sensible regime. They said, okay, we think you could do half time at school. So even on the days you feel well, you don't go to school on that day if it's a non-school day. Even on the day you feel grotty, you go to school that day, and you keep this regular routine, because otherwise, I think what you've experienced, Nicola, is a sort of boom and bust. You try to do too much, and then you're absolutely flattened by it. But this was God, how old is he now? He's 29 now. You know, this was 15 years ago. You know, this is a known thing. Why have people like Nicola had to fight over this? You know, if you've had an incredible viral attack like COVID, even if it's attacking all sorts of areas of your neurological system. Why do you think it would just necessarily go away again? It beggars belief. And Nicola, I'm really sorry, and I'm dead pleased that you came and talked about it. And thank you.
It's
It's
I
just so
know people
depressing how we don't learn from the past, isn't it?
absolutely, and I know well. This is the purpose of that one says this is the purpose of the inquiry to learn. But I think you're right. There are lessons that hadn't been learned that should have been learned. I think people sometimes have this, I don't know, magical thinking. They will not get long COVID, but I thought Professor Chris Breitling made a point that it is not simply the individuals who suffer this terrible condition. Um, the fact that there's no framework for dealing with the resulting long-term conditions that result from the pandemic. It's not only personal impact, he said, but it's the social and economic impact. And we may be, I don't know, at the beginning of an explosion of things that it's going to affect us all, even if we do not have long COVID ourselves.
Absolutely. Well, talking from a personal perspective, in terms of the economic factor, I have gone from working full time to 18 hours a week. I have spent thousands and thousands of pounds trying to research and try so many different things just to see if it will help my symptoms. I have, oh my goodness, I've done this. I've done so much just trying to help myself. And I know so many other people have been in the same situation as myself. It is, it's quite upsetting to think we have basically been left to our own devices. Even the long COVID clinics that are set up, a lot of them aren't fit for purpose. A lot of them aren't actually giving the correct treatment or the most appropriate treatments to each person, because I've heard from so many other people that they're in the same sort of situation as I am, where there's not enough evidence behind it, so we can't give you the treatment. Like, we're nearly 5 years in now. How long is it going to take to get enough evidence?
Another witness we had this week was Dr. Paul Crisp, and I think, Nicola, you wanted to talk about his testimony. He was also questioned by Pete Weatherby, who represents us.
Sure. So NICE is, that stands for the National Institute for Health and Care Excellence. And their role is about providing medical professionals with guidelines and guidance. That's what they do. And one of the problems with the guidance that they were putting out was that they have a stakeholder list which they go to and say, give us a sense check, is everything in here okay? But there are no disability charities on that list of stakeholders. He explained that they do reach out to disability charities and engage with them on specific topics, but that they don't go to them about generic guidance. Because they don't want to overwhelm these sometimes quite small charities with dozens and dozens and dozens of papers. The problem with that is the unintended consequence of that guidance. If they don't think it's going to have a specific impact on disabled people, they won't send it to the charities. But they don't know what they don't know. And so the inevitable happens, and generic guidance won't take into account the needs of disabled people and what adjustments should be made for them. So when they're looking at infection prevention and control guidance, there was nothing in there that allowed for deaf people who need to lip read, for people with Down syndrome who won't understand why people are wearing masks around them and find that scary, and not understand why they have to wear a mask, which is uncomfortable. They won't have those adjustments made within the guidance that is supposed to apply to everyone. And yet they are automatically, by not consulting with those charities, they are automatically excluding disabled people or people with specific needs. And we all saw that happened, and they would then have to go back, and there were delays whilst the guidance was rewritten to allow for these reasonable adjustments. And we understand that, they were working at pace, but in the meantime, people were suffering whilst they were getting that feedback and redrafting. Whereas if they'd just done it in the first place, it's just, again, this oversight of these invisible people who are just being left to suffer until charities are able to kind of barge their way in and say, hang on a minute, our people are suffering because of this. So that was the first striking part of his evidence. The second part was the clinical frailty scale. The guidance that came out at the start of March said that everyone should be assessed in hospital by reference to the clinical frailty scale. However, he also agreed that that's not suitable for anyone under the age of 65 or anyone with stable disabilities. Even more astonishing is that they needed the disability charities to get in contact with them and to point out that the clinical frailty scale includes criteria such as people who need help keeping their finances in order, preparing their own meals, or help dressing. Because if you're frail, you may struggle to do that. But that also applies to people with autism or learning disabilities. So a 22-year-old with autism on the clinical frailty scale would be considered frail, even though physically they aren't. And that would have an impact on the care that was provided. And, Dr. Crisp conceded that this was an unintended consequence, but it's something else that could have been avoided had they consulted with the disability groups at the outset. So that's the second striking part of his evidence. And then the third part of his evidence, which is what we asked him questions about, and this was, as you say, the target oxygen saturation levels. So usually the target level is between 94 and 98%. That's pre-pandemic. So in April 2020, Nice issued guidance that said the target would now be reduced to just 92 to 96%. And it was then reduced again to 90 to 94%. Now, Dr. Crisp said, oh, that was actually NHS England guidance. We just put it on our website. But every time someone says, well, we never ran out of oxygen, that may be true, but it's only because you were rationing it. And the fact that the target oxygen saturation has gone back up shows that that wasn't what was clinically best for people. It was rationing of care. Nicola R., I can see you shaking your head, your mouth agape at some of this. Obviously, working in the NHS Scotland, is this something you were aware of?
It wasn't actually. I don't really work in an acute hospital, so in terms of the amount of patients that we would provide oxygen to, they would be minimal. But I'm quite horrified to hear that. That's not something I was aware of before, and that is something that would be quite detrimental to so many people, to be having target oxygen levels of 90% in a fit and healthy person because they have something like COVID. It is a bit horrifying, really. When I was admitted to hospital with COVID, I know my oxygen saturations were incredibly low. They were in, I think, the mid-80s, which is why I was started on oxygen. But I think I was so unwell. I don't actually know what target levels that they were getting me into because I did not know what was going on really. So yeah, that's very interesting to find out.
Julia, I saw you nodding too when Nicola B was talking.
Yes, I was talking to an intensive care consultant who actually wrote a piece for our website anonymously, but spoke out quite strongly. And that was one of the things, she said this was simply wrong. This was denying people their best chance of survival. And you have to come back again to principles. And you think, hang on, the NHS puts the patient at the heart of everything. And the patient access is equal for all. So you just can't have these sorts of, oh, well, if you're old, you might not get it, or we might ration it anyway, or if you're disabled, you might not. It's simply fundamentally against everything that we stand for. And yeah, sure, we understand that this was crisis, but I also was speaking on behalf of the Patients Association, who feel very passionately about the denial of access for people. And one of their respondents to their survey said, we haven't had an NHS for this period. We've had a COVID emergency service. We haven't had an NHS because a national health service is something we all own, we all pay into, and it should be ready for us at our time of need. Sorry, I mean, that sounds a bit pie in the sky, but I think in times of crisis, those are the moments you actually need to cling on to your fundamental principles more strongly than in normal days. But anyway, that's I probably shouldn't have come in on such a clinical discussion, but when I read this from the intensive care consultant, who was very angry about many of the things, for instance, she talked about the way that many research projects were just automatically stopped. She was a critical care consultant, and they had a research project on best nutrition for critically ill people, which was just stopped. And so much of and she said it wasn't that they didn't have the person power to do it, because so many other areas of the NHS were sort of closed down. There were well qualified, willing people, who could have done it. So it was like we were sort of rabbits in with a headlights, and we're just sort of frozen with terror, and we lost the power to think.
I think one thing that's really frustrating for the COVID bereaved is, going on from what you're saying, Julia and Nicola B, when this witness, I believe, was asked directly, was this because there was a lack of supply? Was it a supply problem that made this decision about the saturation? And he said no. And I think some of us have become very cynical again and again in this inquiry. Actions were taken that we believe were because there weren't sufficient supplies, services, whatever. And it keeps being denied and denied and denied. And we feel like we're being gaslit. And Nicola B, we had testimony from Professor Helen Snooks, who's listed as an expert in emergency pre-hospital care and shielding. And I know you have some thoughts about her testimony.
Yes, so the number of topics she had to cover was immense. It goes from calling 111 or 999 right the way up to the doors of the hospital. But she also had a lot to say about the shielding program. Actually, her conclusions was that the shielding program didn't work, not because shielding is a bad idea, but because people who were told to shield were de facto clinically vulnerable or clinically extremely vulnerable. But that means that they also have a higher level of interaction with healthcare by virtue of their underlying conditions. And until we could make healthcare settings a safe place for someone to go, any shielding work they were doing was completely destroyed by going into a healthcare setting and there being poor infection prevention and control. Nicola Ritchie has just explained that as a healthcare worker, she was fit tested for a mask, but wasn't allowed to wear it because she wasn't going into areas where aerosol generating procedures were being carried out. And yet people with COVID were coughing and spluttering. And as we know from Dr. Barry Jones from Canter a few weeks ago, a cough is a cough is a cough. So that kind of madness in healthcare settings just means that people who are shielding can't go to healthcare appointments. So that's one part of her evidence. The other part of the evidence was about ambulance dispatch. So if you are categorised as category 1, that's the most urgent. And if you're breathless, struggling to breathe, categorised as category 1, an ambulance is supposed to be sent to you within 7 minutes. During the pandemic, she said that Protocol 36 was brought in, and this was to assess calls of patients with suspected COVID infection. And this, she said this was introduced around about April 2020. And she explained it was a specific way of asking questions of callers with symptoms that might be COVID, and to assess their need for an emergency response, because they felt that the generic system wasn't able to correctly categorise people. It wasn't taking account of specific COVID symptoms that we were becoming aware of. Now, all of that sounds fine. What she didn't say was what Protocol 36 actually did. If you rang up saying, I'm struggling to breathe, you're categorised as category 1. Once Protocol 36 was brought in, if you rang up and said, I'm struggling to breathe, I have no COVID symptoms, you were categorised as category 1. If you rang up and said, I'm struggling to breathe, I do have symptoms of COVID, you weren't categorised as category 1. You were put into category 2. With category 2, the target time for an ambulance is 18 minutes. Now, if you are struggling to breathe, the reason for it doesn't matter. The need for that ambulance is just as high. And you don't necessarily have those extra 11 minutes. So, whilst on the face of her evidence, it all sounded quite reasonable. And she specifically said that there was a need to not over respond to people because that put pressure on the system. And also they needed to make sure that they kept the healthcare settings and ambulance crews safe from suspected COVID cases. But again, if you're struggling to breathe, you still need that emergency response. And this comes back to anyone claiming we were never overrun. Well, if you are automatically downgrading the emergency response for someone if they have or are suspected to have COVID, then it kind of makes your targets a little bit easier to achieve. And I don't think anyone listening to her evidence would have quite understood what she was actually saying about Protocol 36 and the impact it had on people.
I know many of our members, this kind of thing is horrifying to hear because you can't help thinking, Nicola, oh, my loved one died because the ambulance was late coming. And it's just awful. It was like they were, again, this feeling we have, and I might be wrong, but it's a feeling we have that our loved ones were thrown to the wolves by this kind of thing. And as you say, the gaslighting goes on, where they say, no, the system never collapsed. But as you say, it only collapsed by, in my view, sacrificing many people who had COVID or symptoms of COVID. Julia, could I ask you, I don't know how much of the testimony this week you got to hear or read, but what was your standout moment? Did you have a standout moment or witness?
I think what I would like to say, and I'm very moved that it's the COVID bereaved group who have invited me to be here today, and I thank you for that. My deep sadness is that there were so many ways of bereaving people that were not directly because of COVID. It was because of the impacts of the the measures taken against COVID. And what I think it did for, I don't know, hundreds of thousands of people, and I do have figures here, is deny people the chance of a good death, because we are all going to die, and we know that. But the fact, and so maybe perhaps 12 to 14% of people in those terrible years died of COVID. Another 12 to 14% of people died of dementia. But that still leaves, 70 something percent of the people who died who just died for all the other reasons that people die from. And not to have their relatives with them at the time of their passing, and not to have all that we've learned about the dignity of death and the way of achieving a good death. That for me was the worst thing. And that's the single thing I would like to have changed.
And Nicola R., again, I don't know how much of the testimony you were able to hear this week, but did you have any standout moments or standout witnesses?
I have a couple of standout witnesses from the week. I thought Dr. Powell's testimony was absolutely fantastic. So many of the things that she said resonated with me so much. Things like the things that she'd been through, the barriers to accessing healthcare on a different level to anyone else, really. How the fact that she now has to have a blue badge, the symptoms that she's been going through, and the fact that she's been told to exercise more, all of these things are things that so many of us can resonate and understand completely, that we have all been through so many similar things. But the fact that she then had the fact that she was a hearing impaired person on top of everything else must have been so incredibly isolating at a time when healthcare was so difficult to access in the first place. It was so difficult for everyone. So yeah, I think she was one of the standouts for me, but also because of the fact that I'm trying to promote long COVID as much as possible. I thought Natalie Rogers was amazing also. She was such a good witness. She gave so much good evidence about the financial harm, the talking about the fact that we should be classed as clinically vulnerable as long COVID patients, and we're not. We can't access things like the antivirals. We can't access things like the long COVID, the COVID vaccine, because we're not classed as clinically vulnerable. She spoke about the inequalities in healthcare, the difficulties accessing healthcare, and the fact there's so much more investment in research needed into long COVID. Because at the moment, the research it's minimal. There's not enough. We keep getting told we have no evidence, so we can't treat you. So do the research, get the evidence out there.
Yes, thank you, Nicola R. And I agree. I think it was an incredibly eye-opening and educational week of testimony for those of us who don't know enough about long COVID and the consequences. And I agree, the moments and the witnesses you mentioned were incredibly powerful. And Nicola B., what was your standout witness or moment?
It's difficult to pick one witness this week. For me, this witness, I think, is all about the invisible or the forgotten people of the pandemic. We had a number of impact witnesses as well as a number of experts. But the overriding feeling was just how any of the rules, any of the guidance, any of the support that was supposed to help, it really just looked at what the typical UK person was and what they might need. It really didn't look at what a deaf person may need to access healthcare. It didn't look at what a disabled person would need to access healthcare. It didn't look at what a person suffering with dementia would need just to go on existing, let alone access any healthcare, because their support in terms of family visits was completely removed. it really didn't look at anyone outside of that typical person. And so an awful lot of people with disabilities, people with additional needs, people suffering with mental health, people who were suicidal before the pandemic, let alone as a consequence of the pandemic, there was nothing really in place to help them to cope with the pandemic. And that's really what this week's evidence has been about for me.
As usual, I just thank you all, Julia and Nicola R, for coming in and talking to us. The podcast means so much to the bereaved, to our members, and I really thank you.
Okay, thank you again, all of you, for having me, and Nicola, more power to you. Okay, thanks. Bye-bye.
Thanks, Julia.
And we're so grateful that you were able to join us today, Nicola, because I know you will pay a price for it, because that's part of it. You talked about your spoons of energy, and I know you've given us at least a couple of spoons today, and we're so grateful.
Thank you so much for having me. I really appreciate it.
And as always, Nicola B, I thank you for organizing it all and steering us through it so magnificently. So thank you.
Thanks, Lorelei.
Thanks for listening to this instalment of the COVID Inquiry podcast. We hope you found it insightful and interesting. If you did, please rate us on the podcast platform you use and share the pod with friends and family who may value this type of commentary. We're looking forward to you joining us next week for more expert commentary, opinion, and insight into the COVID Inquiry evidential hearings.